So today's talk really is mainly based on our experience in the last 12 months. So at the start of the COVID pandemic, we know that a lot of these patients will be spending quite a lot of time in the ITU, intubated, and some of them had tracheostomy. And we are all aware that patients can develop complications, airway complications, voice or swallow complications from intubation and tracheostomy. So we started collecting data, and we collected the data the first 3 months of the pandemic period. So this is just an early report from a cohort of patients. We hope to follow these patients for another 12 months again, and to see if there are other longer term complications that will need to be managed. So all patients that were admitted in the ITU were reviewed, and so that includes both COVID pneumonitis patients, patients that have had respiratory failure from for other reasons, and patients that have had like major surgery and they needed to be in the ITU. The reason we've done that is because we want to compare across the board, knowing that COVID-19 is a respiratory tract disease. We were expecting that there will be some more complications in the airway system, like edema, scar formation as well. So each patient that were discharged will follow up in our clinic, either in the ENT clinic or in the critical care clinic. So essentially, our critical care consultants have got a routine clinic that they review patients that have been discharged from the ITU. And it was a very good system actually, because we were able to use that opportunity to capture patients that present with airway, voice, or swallowing problem. So anything like flagged. So we use questionnaires that is probably known to most of you. There's the AVS questionnaire, which is an airway, voice, swallow. So it's just one A4 paper questionnaire that's about the patient's severity of breathing, voice, and swallow. We also use the VHI-10 score and then the EAT-10 score. So how it works was, at the critical care or the initial visit, we give AVS, which is airway, voice, swallow questionnaire, as a screening tool. And if the patient think that they've got some problems with either of the airway, breathing or swallow, then we do a full assessment for the patient by giving them the full VHI-10 questionnaire, the EAT-10 questionnaire, and we invite them to the clinic for flexible nasal endoscopy. So that first few months, we had overall 129 patients, out of which 86 were admitted due to COVID pneumonitis, 17 due to non-COVID respiratory failure, and then 20 were following other reasons, maybe some other medical conditions or following major surgery. The age range of the patients in the ITU at that time is very much similar across the board. You can see the average is 52, 53, 55. And then there are more male in all the groups, but there are far more males with COVID. This is something that we all know now, that male are more affected, are more risky than female. Maybe is it because of the lifestyle, or we still don't know the reason, and we're not sure whether this is genetic. And then we assess the upper Q, which is the severity, the anesthetic severity as well. So we also looked at the length of stay in the ITU, and then this is the average for the COVID pneumonitis 15, and then there's the non-COVID respiratory failure 20, and then the others 15. We looked at the difficulty of intubation. It's similar across the board, the number of intubations as well. And then we looked at the endotracheal tube size. You can see they are not much different. And then the maximum cuff pressure. This is important. We looked at it because sometimes excessive pressure on the cuff can be the cause of the subglottic stenosis. We looked at the duration as well, and then the whether the patient has a tracheostomy, and then the size of the tracheostomy tube, and then the cuff pressure as well. So at the follow-up clinic, we assess the airway, the voice, and the swallow. And you can see overall from the screening, there was higher number of patients that as COVID pneumonitis patients that came back with complications from either breathing difficulty, changes in their voice, or dysphagia. So when we break down into each the indices, so the airway is by far the highest of them, and then we have dysphonia and then dysphagia. So now we know that there are higher rates of dyspnea or stridor, dysphonia, and dysphagia reported by patients that had intubation post-COVID pneumonitis. We embarked on a multidisciplinary approach whereby we work together with ENT, SLT, anesthetic, or ITU intensivist, and respiratory physician, because these patients may come through any of this specialty. So we have like a database sheet whereby we save this information and we analyze it together as one data at the end. The most common complications that I have come across in my patients are scars on the vocal cords, which these patients present with hoarseness in their voice. And some patients have cryoarytenoid fixation, and other patients have had posterior glottic stenosis, just right where the endotracheal tube sits in the posterior glottis. We've come across tracheostomy site granulation from inside, which some patients actually present with intermittent stridor as a result. We've come across A-frame trachea and then vocal cord granuloma. So I'm just gonna run through a few of the cases that I've treated in my clinic here. This patient was intubated for 2 weeks, and later on we diagnosed the patient with posterior vocal cord glottic scar, and the patient presented with stridor. So you can see the vocal cord is in the paramedian position. So at this point, the patient hasn't got a tracheostomy, but he's sort of struggling to breathe. He can't walk up a flight of staircase without having a stridor, and he's been in and out of hospitals a few times, where we give him adrenaline and steroids injection. And so I took the patient to theater to examine him and treat the patient. So this is laryngoscopy. This is tracheal vocal cord spreader. So you can see the scar there at the back, and this was what was feathering the arytenoids. So I used a sickle knife to cut the scar. This is under tubeless jet ventilation, and I use a balloon dilatation. This is a 15mm Boston balloon, and then injected depamedron steroids there. And this is the patient 2 weeks post-op. This is just local anesthetic spray so that I can examine the subglottic area as well. And this is so the tracheostomy, actually what happened here was this patient turned up in the A&E, and somebody with the tracheostomy tube fell out, and somebody passed the tube in the wrong sort of place, and it went outside the trachea. So that was what I was showing you there. Right, let's go back again. Right. So I'm just gonna play this for you again, and you will see that. So the tracheostomy was inserted in A&E, but you can see the side of the tracheostomy there is not within the trachea. Luckily, because it was after the operation, so the patient was able to breathe. You can see the glottis here, it's a lot better. This is just 2 weeks post-operatively. This is another patient that had a COVID tracheostomy granuloma, and patient had intermittent stridor. So because of the comorbidity in the patient, it was risky to take the patient to theater for a general anesthetic. And we have an office procedure whereby I carry out most of this local anesthetic procedure there. This patient has got the tracheal stomach granulation, and I use the blue laser to ablate it. I'm just going to play it for you now. So this is just examination. You can see the granulation tissue there, and this is why the patient has been having this stridor. So each time it gets bigger and then narrows the airway. There's another granulation lower down there as well in the posterior tracheal wall. You can see that. So the rest of the trachea seems fine. Again, this is just where the intubation tube was lying. You can see the line of hence the granulation there. So this was the procedure in the office. And I used local anesthetic droplets and used blue laser. So you can see the laser there. Just melts the granulation down. The patient is wide awake, chatting to us if she wants. Right. You can see that I did that one at the bottom as well. And this is the patient 4 weeks post-op. The granulation has gone completely. So the granulation was there. This is just another area that's right now. And when I reviewed the patient back in the clinic, everything has cleared up, and I've now discharged her. So this is another patient again that's had percutaneous tracheostomy, and the patient has been having breathing difficulty, and you'll see there's a tracheal cartilage in there. So that's getting lots of granulation there. It's causing patients a problem once the granulation builds up. So you use the forceps to pick it up, and then you use laser to just ablate it. Again, this is all in the clinic. You all right? Right. Again, this is another patient that's had COVID pneumonitis and was intubated, and the patient has been complaining that the voice is getting tired and she does get short of breath intermittently. So what in the clinic, initially, it doesn't look like there is a problem at all. The vocal cord is moving fine.
1, 2, 3, 4, 5.
So the question is, where is the problem here? But when you look closely, you can see there is a breach. See that? That's the problem, that breach there. It is restricting movement of the vocal cord. So I took the patient to theater under general anesthetic. I used laser to cut that scar. This is just the trachea, checking that there is no other lesions. So that's a CO2 laser, and then remove that, and then inject depomedron steroids to discourage scar or granulation formation around this area. And this is the patient's 12 days post-op.
1 to 5 for me.
1, 2, 3, 4, 5.
See, the vocal cord is moving much easier. There's no band there anymore. You can see the posterior glottis. Fine. That's the patient sorted. This is another patient, again, post-COVID pneumonitis, and patient has got a huge granuloma there. You can see it there. So the complaint that this patient had was a choking sensation when she's lying down. And the patient has got some other comorbidities, so we could take the patient to theater. So we offer this patient procedure in the clinic under local anesthetic. You can see like a ball valve effect. This is just a local anesthetic so that I can examine it thoroughly. And that's the laser there. I use the laser to just weaken the stem. And I use, this is a transoral forceps. Then grab it. And then take it out. See, that's it done. Right, again, this is another patient with symptoms of tickling in their throat. Again, this is post-intubation. So you see there's a granulation tissue there, which is growing. I give the patient
So we can see what tickling is.
It's going to last for 3 months, but doesn't have complication at all. So in the end, I had to laser and then remove it in the office. So this is a procedure there. So it's not going to be local anesthetic to make it numb. And I use laser to just coagulate the pedicle, the base, before taking it out transorally with a forceps. So this is a transoral forceps. Grab this and run away with it. So this is it, and the base where the bleeding is, I use laser to stop any bleeding there. You can see that. So this last case, actually, it wasn't a COVID patient. This patient had intubation 3 years ago and only just presented to us last year with stridor. The point I'm trying to make here is that this COVID patient, 3 years down the line, 5 years down the line, we could still be having complications with stenosis, hoarseness, or dysphagia, because the scar formation may take a long time before it will reform. So this patient has got a very stenotic posterior glottis over there. So what I did was I had a look and then cut it. Here I was just palpating the arytenoids, use the vocal cord spreader, and then cut the scar. So this is steroid injection, Depomate 40 milligrams. And then use sickle knife and scissors. And then use the balloon dilatation. But if you just leave it like that, it's going to contract again. So what I did was I put lateralization suture. So I put suture from outside to inside and then lateralize the vocal cord process in abduction on both sides. And I took it out weeks later. And the patient is fine now with the breathing. So this is afterward. Right. So in conclusion, we should expect long-term complications from these patients. And sometimes this patient may be presenting to the respiratory physicians and they may think it's pulmonary cause, but it's always good to examine the larynx and the subglottic area as well. And this is why it's very important we have a multidisciplinary approach in managing these patients. And also, if you want to learn any of these procedures or any laser, we do run a phonosurgery course in London and in Manchester. So you can find our details in www.phonosurgerycourse.com. We had to cancel last year because of the COVID pandemic, but we're hoping that as soon as the COVID pandemic is over, we're going to resume. It's a fresh dissection course, hands-on. I think we're well good in time then, so hopefully we'll have plenty of time for questions and answers.
The first question we've got is, can you describe how you use the transoral forceps? Do you get an assistant to hold the camera?
Yes, so the forceps is curved at the distal end, and I have an assistant to hold the camera. I would have sprayed the patient's nose with 5% lidocaine, and then the mouth, I sprayed the patient's mouth with 10% xylocaine. And I hold the patient tongue on the gauze with my right hand, with my left hand, and then the forceps in my right hand. So it will be direct view on the monitor. So yes, you need an assistant.
Perfect. Our next question is regarding what criteria that you use to decide whether a case is suitable for local anesthetic or general anesthetic.
So, so there are a few criteria that I use. One criteria is if a patient is not probably strong enough for a general anesthetic. If the mobility is quite high, then I will offer them local anesthetic. And also the patient would be able to have been able to tolerate, because some patients may have a strong gag reflex, although I've probably had just one or two cases that I had to cancel because of a strong gag reflex. Most patients will be able to tolerate it. And also, it's quicker for me to get the patients in the office to do the procedure. With this, during this COVID pandemic, main theater is shut for routine operations with only emergencies. So there is limitation. And luckily in the clinic, we can do this because we have a full PPE and Papa hood as well. And we have an air filter as well in the room. So those are the criteria that I use. And also patient's choice as well. I had to have a chat with the patients. Some patients will just say, well, you can take it under local anesthetic. Why would I have a general anesthesia for something very minor like this? And patients like it actually because they'll just come in and out. They don't need any admission. The maximum they stay in the department, maybe 1 or 2 hours. So they come in the morning, do the procedure, they hang around for half an hour, and then we let them go home.
Perfect. I think just following up on this, there's another question regarding whether you've got any photos of your setup for laser under local anesthetic. That would be quite
Yeah, I showed
useful.
it. Yeah,
Full screen.
yeah. So this is the setup there. You can see I've got the Papa hood there as well.
Perfect. So the patient sitting opposite, and you've got those
Yeah, the patient.
two,
Yeah, the patient is sitting.
and
Yeah,
and the two screens, one that you're looking at, and one for your assistant as well.
yeah. There's another screen behind me for the patient on this side here for the patient to be looking at. So this is just a big teaching screen because sometimes I have visitors coming, and this is my screen there. So I've got 3 screens in the room.
The next question that's in the chat is, what's your laser of preference? And do you primarily use CO2 laser? And usually, what sort of settings would you use it on?
In the office, I use blue laser, which is similar to KTP laser because it's a fiber laser and I can use the fiber through the channel endoscope. And I use it for patient that has got like vascular lesions, say papilloma, vocal cord granulation, things like that. In the theater, again, if I need to excise a lesion, I use CO2 laser because it is more precise in excising lesion, and I do that under general anesthetic. So if I have a big lesion that is probably not easy to take it out in the clinic, I put the patient to sleep and then do that under general anesthetic. And I use the laser. And for the laser, the CO2 laser, it depends on what tissue you're going to be removing and the thickness of the tissue. If it is a procedure on the vocal cord epithelium, you only need about 1 or 2 watts. Say if it is a vocal cord nodules, you need, say, 1 watt to take it out with. But if you have a big granuloma, you can probably use 3 watts. If, however, you're going to take a big tissue on the false cord, whereby you're not worried about damage to the underlying vocal cord, then you can go up to actually 5 watts. But anything you're going to be doing on the vocal cord, you need to keep very, very low power. It's best to start low and then increase it. That's for the CO2 laser. For the blue laser, or KTP, they are very similar. I use probably up to 4 watts and in some cases up to 10 watts. But for the KTP laser or the blue laser, the duration of the firing and then the switch off is important as well. So you need to alter that so that you don't have the firing so much there. So with time, you'll be able to understand or to know which cases will be more suitable for CO2 laser or the blue laser. But the ballpark is for blue laser, they're good with vascular tissues because it has the coagulation property in it as well. For a tissue that is full of fluid, then it's better with CO2 laser.
So Ali is asked about whether these complications you feel are contributed to by COVID specifically, that increases the volume of the complication that we are seeing, or do you feel that it's primarily related to prolonged intubation / lots of tracheostomy that we're doing at the moment?
I think it's both because COVID is a respiratory infection. So some of these patients may probably have high risk of having edema in the respiratory wall, and that includes the vocal cord and the trachea as well. But also with the COVID, because most of them have a prolonged intubation, so that's compounds the problem. And also because a lot of the patients are obese and they needed to put a bigger endotracheal tube. And so that again, because of pressure necrosis in the posterior glottis, it increased the risk of them having complication. And a lot of them were having tracheostomy as well because the ITU was getting too full and they have to really extubate patients. And also if you're gonna need to ventilate patients for more than 7 days, then they usually prefer to do the tracheostomy in the second week of intubation. So it's a combination of factors, but mainly really the intubation, the duration of the intubation, and then the size of the endotracheal tube.
Brilliant. I think following on to that, we've got a query from our critical care colleague, Dr. Tricklebank. So Stephen's asked that is there anything that we can do to prevent granulation formation at the time of tracheostomy insertion and during weaning, or do we just have to accept it as a complication of prolonged ventilation?
This is tracheostomy site granulation, isn't it? Yeah, with the tracheostomy site granulation, it's something that probably we will have to accept because I don't think the technique of the tracheostomy will matter much regarding the development of the granulation tissue. The granulation tissue that causes problem is the internal one. But for the endotracheal ventilation, the size and then the duration certainly has impact on that. And also the duration of the tracheostomy tube, the longer the tracheostomy tube there, the more the risk of having a granulation formation as well. So if the patient doesn't need it, training and then decannulating patient at the earliest possible opportunity will probably reduce the chances of the granuloma formation.
Perfect. Thanks, Yakubu. So the next couple of questions, I'll sort of put them together because they're both related to the blue laser. So one question is about the risk of ignition with the use of blue laser, and the other is about the effect of the blue laser on surrounding tissues from point of view of its heat.
Right. So to answer the first question, to have fire in theater, you need 3 things. You need oxygen, you need something that is inflammable, yeah, and you need the ignition. Yeah. So the ignition is the laser, and then oxygen. We don't use oxygen in the office, so there's no fuel for that, and also there's no endotracheal, so there's nothing to catch fire. So I've never had any fire incident with office procedure with the laser, because there are 2 things that are not there. So you shouldn't have fire at all with that. The second question, will the heat of the blue laser affect surrounding tissue? Yes and no. Yes, if you leave the laser fiber for a prolonged period, and the heat will transmit to the surrounding tissue. And know if you just flash the laser fiber and then have a time of rest. And also on the setting on the laser, you can, so when you press the pedal, although you're seeing the flashes of the laser, you can turn it so that the time of the hit will be, say, 60 seconds. And then the time where it is off is like 300 milliseconds. So 60 milliseconds on and then 300 milliseconds off. So that gives us a cooling time. Yeah. And with the blue laser also, it has a non-contact cutting. So that's the difference between the blue laser and the KTP. With the KTP, you have to insert the fiber into the tissue before you be able to cut it or burn it. With the blue laser, you can stay, say, a few millimeters away from the tissue and you'll be able to cut or melt or ablate the tissue. Yeah. So it's really how you handle it.
Perfect, perfect. So the next question is from one of our speech and language colleagues. Do you find any immediate deterioration of voice post some of the surgical procedures?
Yeah, almost most patients will have changes in their voice. Luckily, some of them is just temporarily from the bruise in there. And sometimes for the general anesthetic, there will be intubation symptoms as well. So it is for this reason, all our patients, we refer them to speech therapy, and the speech therapy, normally they know these patients beforehand, and they'll have good chat with the patients. And all our patients, a week after any procedure in the larynx, the speech therapy will phone the patients to chat to them, just to reassure them as well, and to see if there's anything that is serious that we need to see the patient quick as well. So that is very important for the patient because it gives them peace of mind. But yeah, temporarily changes in the voice, not permanent, just temporary because of the bruising. And also we advise patients to rest their voice the first few days. So by the time they start talking, they may not even notice the changes in the voice.
Perfect. So we've got another question from Ali asking about whether there's a difference in outcomes in dividing scar tissue by CO2 laser vis-a-vis cold steel.
Cold steel and CO2 laser. Well, the CO2 laser is more precise, less bleeding. Yeah, and it is probably quicker. The cold steel is more bloody, and half of the time your scissors or your sickle knife, you find that they've been in your tray for maybe older than before you were even born. And sometimes the decontamination team can damage the tip of the sharp equipment as well. So it's not very reliable. So for that reason, most of my cuttings, I use the laser, the CO2 laser. It's very good in cutting precisely. And the depth of heat is not as deep as well, just about, I would say, 0.3 millimeter.
Brilliant. I mean, from an outcomes point of view, do you feel that that makes a huge impact on the final outcome that we see?
No, it doesn't. It doesn't. It's how you use it, really. I don't think outcome, yeah, it's just your technique, because you could do a good job with cold steel as well as with the laser as well.
Brilliant. Thank you. The next question is from one of our ENT colleagues who's asked the laser granulation that you showed, the video that you showed about the granulation in the trachea, was that under local anesthetic or general anesthetic?
It's in the clinic. This is the one here.
Yeah, I believe that's the one that they would be referring to. Yeah.
Yeah, this one here. So you can see the vocal cord moving. So the patient was sitting in the chair when I did that.
I think it's quite amazing how far we've come with office procedures and what can be done in office.
It's remarkable. Yeah, because throughout this COVID lockdown, we're doing full operations in the office. In a day, we'll probably do like 4 patients in the office, which you couldn't get through that easily in the theater.
Yeah. We've got a couple of questions from Kwang Lei, who is asking how can we avoid affecting vocal cords when using laser to cut nearby lesions under local anesthesia?
By having a very good local anesthetic, the patient does not feel it, so the vocal cord doesn't move much. Yeah? And also, when you fire the laser, you need to do that intermittently. If the laser hit the normal tissue just once, quite most of the time it doesn't cause any damage at all. So maybe just slight bruising, no permanent effect. But it's when consistently you're hitting in one area, that's when you're gonna cause damage. So although the vocal cord moves, but it doesn't move a lot if it is well anesthetized, because again, the patient doesn't feel it.
Perfect. I mean, I think in addition to that, when I was observing one of the procedures in clinic the other day, I noticed that you'd ask the patient to continue to suction secretions from his mouth and minimizing swallowing. So probably that
Yeah, yeah.
contributes a bit as well.
Yeah, that as well, because if there's less secretions, then the patient will not be swallowing a lot. And also I have the patient screen. So the patient is watching on the screen. They can see what we're doing as well. And they can see when they move their vocal cords, they can see how we're struggling. So they actually help us. We had a chat. So we chat with the patient, show them what we're doing. We're talking to the patient throughout and they're focusing on that. So little things like that does help.
Perfect. I think following up on that, there's a question about what did your patients describe their feeling when you use laser under local anesthesia?
So for every patient, we do a pain score. So the pain score, we take a pain score from 0 to 10, 0 no pain, and then 10 the maximum pain. And so also do discomfort pain. So we ask them, did you have pain or did you have discomfort? And on the score of 0 to 10 in your nose and in the throat as well. So we assess that. And we were quite surprised. A lot of patients actually, they don't feel much different from the nose. Depending on the procedure, like when we do balloon dilatation, they may have more pain in their throat. But a lot of the patients, there's not much difference between the pain they have in their nose. And most patients, they said there was no pain. They just had discomfort and they were scoring between 2 to 5. We've had patients that have scored 0 in the nose and then 0 in the throat. But we've had the patients that for pain, they will say it's about 10. But actually the patient sat through the procedure, so maybe just perception. And also we're taking the patient's blood pressure and pulse rate as well. If they're having pain, we can see that the blood pressure is rising up as well as the pulse. So we stop and then give them some local anesthetic. And then we'll chat with the patient whether they want us to stop or whether they want us to continue with it as well.
Perfect.
Yeah,
I think
we've not had a patient that we ask us to stop because of pain or anything. And we check with the patient all the time.
brilliant. There's another question about the overall in-office procedures. Do the patients go to a recovery area, and how long do they usually need to remain for observation?
So we have a room next door to our procedure room, and the patient, as soon as we finish, they go over there and the nurse take their blood pressure and pulse rate, and they sit there for half an hour, and then maximum an hour, and then they go home. So we've not had any problems. There was just one patient who finished the procedure, went in, sat there, and had a bit of vasovagal attack, and then but the patient was fine after that, and the patient went home.
Meanwhile, I've got a couple of questions of my own, Yakubu.
Yeah.
And I was quite interested to know what you think about when you're injecting dipomedrone for scar divisions. Have you found found a big difference in injecting prior to dividing or injecting after dividing from point of view of ease of injection or outcomes?
You mean when you say prior to injection, prior to dividing, you mean before you take the patient to theater or
No, in
on the spot?
theater, on the spot when you're about to cut through the scar band.
No, no, no. I've not noticed much difference there. Really. It depends on the size of the tissue, really. Because if it's something very small, I will probably inject before I cut it. Because otherwise, if I started cutting it and then dividing it and then inject, then I won't know where exactly the bulkiness of the tissue is. Yeah.
Interesting.
So I don't think it matters much.
The other was more of a comment rather than a question. This was something that I learned while working with you and being on call these several months. That a lot of patients afterwards who are presenting as a query bilateral vocal cord paralysis are actually presenting with posterior glottic stenosis, which isn't really being picked up or being thought of as the actual pathology. So just to point out to a lot of other people that it's worthwhile thinking of posterior glottic stenosis when you're thinking when you've got someone who you feel may have vocal cord paralysis post intubation in this sort of situation. Would you agree, Yakubu?
Yeah, yeah. Almost invariably, if it is immobile, if it is when you have bilateral vocal cord immobility following intubation, until proven otherwise, it will be either posterior glottic stenosis or cricoarytenoid ankylosis. I wouldn't say dislocation because dislocation is very controversial. It's not an easy joint to dislocate because it's well supported by the PCA, the LCA, and then lots of muscle around the area. But the pressure from the tube can cause necrosis and a scar and diminished movement. And it's difficult to see that in the clinic. But if you want to have a good information in the clinic, you must anesthetize the larynx and pass the scope into the trachea and then come back and then inspect the posterior glottis very nicely. Almost 90% of the time, you'll be able to see the scar there, just in the posterior glottis below the posterior commissure. And when you take this patient to theater, you can palpate the area as well. And also you can do laryngeal EMG. And if you do an EMG in the clinic, you'll find that there will be good nerve signals there. And also some of this patient, there will be some movement actually. Even when you ask them to phone, you can see the arytenoids attempting to move.